As you know, we have been discussing all the aspects of pediatric tubular disease in different sessions. We have also had polling sessions. We have had 5 polling sessions up until now, and today is going to be the last polling session. So make sure that you stay till the end and participate in the polling sessions. As you also know, CME credit hours are going to be granted. Now I will invite Dr. Kalavani to introduce the chairperson for the session, Dr. Sampath Kumar K.
Good evening, everyone. It's my pleasure to invite Dr. Sampath Kumar, who's a senior consultant pediatric nephrologist and head of the Department of Nephrology at Meenakshi Mission Hospital and Research Center in the down south Madurai. And his interest is he is an extensively an academic person, and he has established a fellowship program and a diploma in national board program in Meenakshi Mission Hospital. And his keen interest is towards interventional nephrology, and he's been into various society. Currently, he is a secretary of Nephrology Association of Tamil Nadu and Puducherry. He is also a vice president of Indian Society of Nephrology Southern Chapter. He is executive committee member of Asian Pacific Chapter of Dialysis Access Society. He had been a member of Interventional Nephrology by International Society of Nephrology in the year 2013 to 2019. And he has received the prestigious Dronacharya Award for Nephrology. And he is also a recipient of World Mental Health Leader Award in the year 2020. And he has contributed in various journals, and he is a deputy editor of Indian Journal of Peritoneal Dialysis, and he is also editorial board of International Urology and Nephrology Journal, and he has contributed to various articles and chapters in textbook. Over to Dr. Sampath Kumar to moderate the session and introduce Dr. Amrish.
Thank you, Dr. Kalavani, for this great opportunity to interact with the pediatric nephrologist. My mind goes back to 30 years ago when I started my practice in 1992. One of the first few cases of challenging cases that I have seen and managed was a 6-month-old child who had come to me with a severe renal failure. At that time, we were all thinking that it was likely to be acute kidney injury, and the peritoneal dialysis was done for a few days and there was no recovery. We did a biopsy, and the biopsy showed that extensive oxalate deposits. So that was the entry of mine into the pediatric nephrology, the problems and the challenges. Over the years, I have been dabbling with the pediatric nephrology in my city, where even after 30 years, we don't have a pediatric nephrologist. And I know very well that pediatric nephrology is not adult nephrology divided by 2. And there is lots of intricacies involved in the management of pediatric patients with nephrological diseases. And I'm very happy to chair this section where Dr. Amrish Jain, who is a medical director, Pediatric Kidney Transplant Program at the Michigan, USA. So he's a multiple award winner, and he has had the Teacher of the Year award voted by the Children's Hospital of the Michigan Pediatric Residents. And also he has been nominated for the Excellence in Teaching in Pediatric Award, nominated by the colleagues for exemplary teaching in CMU College of Medicine, and also received the Top Nephrologist Award peer review survey of physicians honoring the adult and pediatric nephrologists in metropolitan Detroit. So we have an exciting session in store where Professor Prasad Devarajan and Dr. Azmeri Sultana will be talking to us about the pediatric renal stone disease. So over to Dr. Amrish to conduct the proceedings. Thank you.
Thank you so much, Dr. Sampath Kumar. This has been so exciting, and we have 2 excellent speakers today, Dr. Azmeri Sultana and Dr. Prasad Devarajan. And the good thing I want to share is that they have a common link, that Dr. Sultana actually trained in Cincinnati Children's for her critical care. So it's very nice to see both the mentor and mentee on the same platform, and we are really excited to hear from them. Our first speaker is Dr. Azmeri Sultana. She's an associate professor of pediatric nephrology at M.R. Khan Children's Hospital in Dhaka. She completed IPNA Fellowship in Singapore, and then subsequently she met Dr. Devarajan at Cincinnati for her critical care training. She is Scientific Secretary of Peds Nephrology Society of Bangladesh and is also co-PI of Pediatric AKI Consortium in South Asia. She has won many awards, and recently she was also awarded the Best Kidney Day Project from International Pediatric Nephrology Association. She has more than 60 publications in reputed journals. I'm really excited to welcome Dr. Azmeri Sultana. Over to you, Dr. Azmeri.
Thank you, sir, for a kind introduction. And let me share my slide first. Yeah, I think it's visible. So thank you, Dr. Kalaivani and organizing team. My mentor, Prof. Prasad Devarajan sir is here. So I'm so grateful to in front of you by this topic. And congratulations for this excellent tubulopathy symposium. I'm really amazed to hear every session. Before going to start, I would like to let you know that I'm not a geneticist at all. And when Dr. Kalaivani asked me to talk on molecular techniques, so it's this proverb came to my mind about myself, that I am like jack of all trades and master of none. So yeah, I'll try my best. Genetic test in tubulopathy as well as other disease in country like Bangladesh is still a long way to go. We are doing most of the tests by private sector and by our neighboring countries, and still it is so much expensive. So why we need this molecular technique or molecular diagnosis? There is a various presentation and overlapping phenotype often lead confusion. So it is the most conclusive tools for diagnosis. And if we know the causal mutation, we can plan the better treatment strategy for our children. And it also helps us to give us the information about the comorbidities, like Bartter type 4 may present it with sensory neural hearing loss, whereas type 1 and 2 may present it with nephrocalcinosis. And for public health perspective, it is also the basis for prenatal and pre-implantation diagnosis. So next couple of minutes, I'm going to talk on how frequently we are going to do molecular diagnosis for tubulopathy and how should we approach if we suspect a case of tubulopathy, what is the genotype and phenotypic association, and what is the role of genetic aspect for diagnosis and treatment of inherited tubulopathy. So genetic pleiotrophy, overlapping phenotype, variable expressibility may influence the diagnosis as well as treatment. Moreover, clinical inconsistency between the same individual with same syndrome may also happen. And solely based on symptomology, often difficult, and our diagnosis would be inaccurate. This recent data from Asia published by Rezontok and his team, and it is published in Asian Journal of Pediatric Nephrology. And they included almost 300 nephrologists around 21 countries across Asia. And they found that most prevalent tubulopathy in this area is distal renal tubular acidosis, which consisted 85.3%. And next to distal renal tubular acidosis, it is Bartter syndrome. And what is the basis for this inherited tubulopathy diagnosis? You can see here that most of the diagnosis is based on clinical history and diagnostic lab. Only 50% disease is confirmed by genetic testing. And on the note, this data derived from where this molecular technique is available, like India, Japan, China, Singapore. So for better understanding, we can divide this topic into the disorder of electrolytes and disorder of water. And we should keep in mind that what inside our body must comes out to maintain the body's interior. Let's have a discuss around the case scenario. This 5-year-old girl with severe failure to thrive presented to us with several carpopedal spasm and tetany. And she was first seen by an endocrinologist, and she referred us for she's suspecting a case of tubulopathy, though mother had history of polyhydramnios during pregnancy, and the child had severe neonatal failure of weight gain at her neonatal period. Her blood report shows there is a severe hypokalemia, hypochloremia, and metabolic alkalosis. Serum magnesium is so low that is 0.2 millimole per liter. Her renal function is normal, and urine calcium creatinine ratio is normal. urine volume is little bit higher. Her blood renin and aldosterone reveals higher level. So what could be the diagnosis? Participants and students, you can write down your answer in the chat box. So moving to this next slide, if patient presented with hypokalemic metabolic alkalosis, we need to measure blood pressure. If patient presented with normal blood pressure or without any hypertension, we should think about when the symptom arises. Usually, Gentleman syndrome presented in early childhood or adolescent period, where if presentation is neonatal onset or early onset, then we should think of Helix syndrome, East syndrome, or Bartter syndrome. So get back to the patient scenario. So in view of polyuria, tetany, and there is a history of consanguineous marriage, and her blood report shows hypomagnesemia, hypochloremia, metabolic alkalosis, and urine shows decreased calcium, that is hypocalciuria. So in view of these findings, we label this patient as Gentleman syndrome. But when we did genetic testing, we found there is a likely pathogenic mutation occurs in KCNJ1 gene, which is ultimately we diagnosed this case as an antenatal Bartter syndrome type 2, though patient presented like Gentleman syndrome. So this is a molecular level of distal convoluted tubular picture. Here is the apical membrane. There is a solid carrier family 12 number 3 carrier protein, that is NCC protein, which is responsible for reabsorption of solute like sodium and chloride from lumen to the cell, and loss of function of this carrier protein by mutation of SLC12A3 give rise to Gentleman syndrome. And mutation of this SLC12A3 also hampered the function of TRMP6, which causes magnesium reabsorption from the distal tubule. So this can explain why Gentleman syndrome may associated with hypomagnesemia. And then there is another protein in basolateral membrane, that is Ki4.1, and it is responsible for potassium reabsorption, and mutation of this KCNJ10 give rise to East syndrome. This table showed that I have already mentioned Gentleman is the responsible gene is SLC12A3, and it is inherited as autosomal recessive. It may be presented with the hypocalciuria, and there is a Gentleman-like syndrome where the responsible mutant gene is RRAGD, which also presented with nephrocalcinosis and DCM, dilated cardiomyopathy, and the East syndrome, which may presented in infancy, inherited as autosomal recessive trait. And it also associated with CNS manifestation like ataxia and intellectual disability, sometimes protectable seizure. And the Helix syndrome, though it is a part of thick ascending limb of loop of Henle, but it is presented with hypokalemic metabolic alkalosis. So I put it here. And here the responsible gene is CLND10, and the gain of function of the claudin 10B complex causes increased magnesium reabsorption along with the tubulopathy and then exocrine gland dysfunction like alectemia and hypohidrosis. So this is a picture of loop of Henle. There is another solid carrier protein. It is solid carrier family 12 number 1. It is a sodium chloride potassium channel protein, which is responsible for the reabsorption of sodium, chloride, and potassium from the lumen to the cell tubular cell. And loss of function of this protein can give rise to Bartter type 1, and responsible gene or mutant gene is SLC12A1. And there is another protein, that is ROMK protein. It is ATP sensitive rectifier inverse potassium channel protein, which is responsible for the potassium secretion from cell to the lumen. So potassium here is the limiting substrate. So in lumen, there is a decreased concentration of potassium. So kidney cell need to secrete this potassium into the lumen to maintain the electromagnetic difference. And also the function of NKCC2 depends on this ROMK channel and the secretion of potassium. So mutation, a loss of function of this ROMK channel by mutation of KCNJ1 gene give rise to Bartter type 2, which is present in our case. There is another chloride channel in basolateral membrane, which give rise to Bartter type 3. It is so severe that most of the patient died intrauterine. And then the Bartin protein in the basolateral membrane give rise to Bartter syndrome type 4, and then 4A, and then chloride channel protein, and the responsible gene is CLCNKA give rise to Bartter type 4B. And there is an intracellular melanocyte-associated protein which stimulated this NKCC2 channel, and for loss of function of this protein can be occurred by MAGED2 mutation give rise to Bartter type 5. This table showed that all of the Bartter types from 1 to 4, this is autosomal recessive, only Bartter syndrome type 5, which is X-linked recessive, and it may be transient and presented at neonatal or antenatal period. And you can see here, I have already mentioned type 4 and 4A and 4B may associated with sensory neural hearing loss, and because chloride channel is also present in the inner ear, so it presented with sensory neural hearing loss in laterhood, and type 1 and type 2 presented with nephrocalcinosis. What if patient presented with hypokalemic metabolic alkalosis and then hypertension? If so, we need to measure blood aldosterone and plasma renin activity. If blood aldosterone is high and renin is low, then we should think of it is primary hyperaldosteronism. If both are low, then we should think of Liddle syndrome. I'll discuss it later on. And then apparent mineralocorticoid excess syndrome, where the involved gene is HSD11 beta 2, which encoded the protein 11 beta dehydrogenase enzyme, which prevent corticosteroid to bind with mineralocorticoid, and the inhibition of this protein causes increased activity of corticosteroid in the mineralocorticoid receptor. In Liddle syndrome, it is autosomal dominant, and the epithelial sodium channel in collecting duct, there is a continuous stimulation occurs by mutation of ACNN1 alpha, beta, or gamma, and there is a continuous reabsorption of sodium causes hypertension and hypernatremia. And in lieu of this hypernatremia, there is a hypokalemia and alkalosis because potassium and hydrogen ion cannot secrete it in the collecting duct, and aldosterone and renin is suppressed. Here is a case report where they showed that a missense mutation occurred in the alpha ENaC channel, give rise to the Liddle syndrome. So major site of the urinary acidification is distal tubule and collecting duct, and in the principal cells and alpha intercalated cells. In this apical membrane, there is a sodium and hydrogen ion exchanger antiporter protein, which is responsible for sodium reabsorbed to the cell and hydrogen ion secreted to the lumen, where this is mixed with filtered bicarbonate to form carbonic acid in presence of carbonic anhydrase enzyme 4, and it is dissolved into the carbon dioxide and water, and carbon dioxide
We are sorry for the interruption. I think Dr. Azmeri's internet may have slowed down. We will try to contact her. Please bear with us.
Sorry, my power is cut off suddenly, so sorry for interruption. So can I share my slide again?
Yes, that's okay. We totally understand, Dr. Azmeri.
Sorry, extremely sorry. So in the distal tubule and collecting duct, there is a diffuse into the cell and formation of carbonic acid again in the cell in the presence of carbonic anhydrase enzyme 2, and these carbonic acid again dissolved into the bicarb and hydrogen ion and go back into the, and this bicarbonate actually reabsorbed from the basolateral membrane by the sodium in sodium bicarbonate symporter. So if a patient presented with hypokalemic metabolic acidosis, we should look out for the urine for low molecular presence of low molecular weight proteinuria and amino aciduria. If it is present, then we should think of any presence of glycosuria. If it is present, then it is generalized proximal tubulopathy or Fanconi renotubular syndrome. If it is not, then we should think of, if glycosuria is not present, then we should think of any extrarenal manifestation is there. Usually low syndrome and DEN2 syndrome, there is a extrarenal manifestation like eye involvement or CNS involvement. Usually DEN1 syndrome is not associated with any extrarenal manifestation. And what if the patient urine doesn't contain any amino acid, proteinuria, or glycosuria? Usually distal renal tubular acidosis type 1 presented with the nephrocalcinosis, and proximal RTA usually not associated with nephrocalcinosis. So this is another child who presented, a 2-year-old child who presented to us with severe paralysis with failure to thrive. He had same type of illness in the severe past 2 years, and he is the third issue of a consanguineous parents. He was found to have hypotonic, diminished reflexes, and his muscle power was 3/5 in all 4 limbs, and there is no involvement of cerebellum or gallbladder was normal. He was severely wasted and severely stunted, and you can see here that in chest there is a rachitic rosary and rachitic chains also present in the limbs. His blood report shows that there is normal anion gap metabolic acidosis with there is a sodium is little bit lower range, that is 133 milliequivalent per liter, hypokalemia, serum chloride is normal, and serum calcium revealed hypocalcemia that is of 7.4 milligram per dl. His urine is more than 5, pH is more than 5.5, and urine for protein and glucose is almost nil. So what could be the diagnosis? Is it proximal RTA or distal RTA? So in view of urine pH more than 5.5, we think of it could be a case of distal renal tubular acidosis. And we done the genetic analysis which revealed ATP6V0A4 gene. So it confirmed the distal renal tubular acidosis. In distal tubule, there is a 2 type of hydrogen ion pump. One is hydrogen ATPase pump and another is hydrogen potassium ATPase pump, where potassium is reabsorbed and hydrogen is secreted into the lumen. Till now, there is no mutation found in this hydrogen potassium derived ATP pump. Only mutation found against this hydrogen ATPase pump, that is ATP6V0A4 and ATP6V1B1, which may also associate it with sensory neural hearing loss. And there is another protein in the basolateral membrane, that is bicarbonate chloride ion exchanger protein, and loss of function of this can occur by SLC4A1 mutation. And this mutation can also associate it with some blood abnormalities like elliptocytosis and hereditary spherocytosis. So there is this 3 distal renal tubular case report published from China, where they explored their genetics and they found that there is one patient, there is a mutation of ATP6V0A4 gene, and patient is there is a compound heterozygous mutation in exon 14 and exon 21, and first is inherited from father and second is inherited from mother. There is another mutation, that is patient 3. There is a novel mutation of SLC4A1, and neither father and mother carried the defective gene. So isolated proximal RTA exceedingly rare and associated with sometimes eye abnormality if it is involved in this basolateral sodium bicarbonate symporter, and the mutant gene is SLC4A4. And another is apical membrane, where the sodium is reabsorbed and the hydrogen is secreted, and mutation occurs in SLC9A3. Whereas Fanconi renotubular syndrome can caused by mutation of L-arginine glycine aminotransferase gene, that is GATM gene, and there is also SLC34A1 gene and Fanconi-Bickel syndrome. This case is reported by one of our colleague, Dr. Kader, and this 8-year-old girl from a consanguineous parents presented to them with severe growth failure and polyuria, and there is a rachitic change, and there is also a disability of walking. And the patient was first diagnosed at her 8 months of age as a renal tubular acidosis, and was on, at that time, she was on in salt solution, that is alkali supplementation. Her blood report shows there is a hypokalemia, hypocalcemia, hypophosphatemia, and also there is a normal anion gap metabolic acidosis. Her urine showed there is a presence of calcium in higher range, and glucose and protein was also positive in urine, and pH 7.5. But on the note, patient was on alkali supplementation at that time. They took a ophthalmologic consultation, and there is a they found and reported that there is a cystine crystal deposited in the conjunctiva, cornea, and then in the fundus. You can see here. So finally, they diagnosed the case of cystinosis, though they didn't confirm it by the genetic testing because due to some financial issues. So in cystinosis, there is a less abundance of ATP in cystinosis cell, and ATP is required for the conversion of cystine to cystinosin, and cystinosin play a major role for the lysosomal exocytosis autophagy, and this cystinosis then converted to cystine, and this cystine helps to synthesis of glutathione reductase, which is a major prevention of the free radical injury in the cell. So mutation of the CTNS gene causes the blocking of the formation of cystinosin, give rise to the cystinosis disease. And if the patient presented in infantile nephropathic cystinosis, this patient, although normal at birth, but they present Fanconi syndrome in early infancy, and they achieved end-stage renal kidney disease by the 10 years of diagnosis. And another is juvenile nephropathic form, and here is the milder kidney involvement. And another is adult onset, where the ocular involvement is more prominent than the kidney involvement. This is a case of Lowe syndrome published from India, and this 9-year-old boy presented to them with profound intellectual disability and recurrent seizures and also rickets, but there is no history of any tetany, polyuria, or polydipsia. But the child had history of bilateral dense cataract, and he required surgery at his infancy for this surgical correction. This boy, his weight was normal, but he was severely stunted, and there is a significant some facial dysmorphism like low set ears, ocular abnormality, prominent forehead, and also triangular mouth. The genetic analysis was done, and they found there is a OCRL gene mutation and confirmed the diagnosis as Lowe syndrome. Now, let's talk about the hyperkalemic metabolic acidosis. We are talking about hypokalemic metabolic acidosis, hypokalemic metabolic alkalosis. Now, what if patient presented with type 4 RTA? So it is divided into two, that is pseudo-hypoaldosteronism type 1. The type 1 is further subclassified in one form, which is autosomal recessive, where the ENaC channel is lost its function, and so sodium is not reabsorbed, and sodium losses cause hypotension. And this ENaC channel also expressed in the lungs and the skin, so patient may present like cystic fibrosis like feature. And another is autosomal dominant, that is the mutation occurs in ANR3C2 gene, which causes the activity of mineralocorticoid receptor. And then the type 2 Gordon syndrome, where the responsible gene is WNK4, WNK1, and KLHL3 and COL3, which actually inhibit the sodium chloride channel in distal tubule. So mutation occurs continuous stimulation of sodium reabsorption from the distal tubule, and this continuous reabsorption of distal tubule sodium causes hypertension, and it also reflexly inhibit the collecting duct to absorb sodium, and thus give rise to the hyperkalemic metabolic alkalosis. Now, disorder of water. So failure of this collecting duct to in reabsorption of water in response to vasopressin give rise to dilute urine. In the basolateral membrane, there is a AVPR2 gene, and vasopressin act on this gene causes increase in stimulation of cyclic AMP, and the cyclic AMP causes the insertion of aquaporin channel, thus water reabsorption occurs. And mutation and loss of function of this AVPR2 channel by the AVPR2 mutation, it is X-linked recessive, and another is AQP2 mutation, which is also autosomal dominant or maybe autosomal recessive, and this gives rise to nephrogenic diabetes insipidus. If APPR2 gene gains its function by mutation, then it gives rise to nephrogenic syndrome of inappropriate ADH. And if nephrogenic diabetes insipidus presented as serum osmolarity will be high, dilute urine, and polydipsia, polyuria. Though magnesium is the second most intracellular cation, but often it is forgotten ion. So what about magnesium pathology? In the distal tubule, there is a TRPM6, which is responsible for the reabsorption of magnesium from the lumen to the cell, and loss of function of this protein by the mutation of TRPM6 causes familial hypomagnesemia with hypocalciuria with secondary hypocalcemia. And there is a thick ascending limb of loop of Henle. There is a magnesium is reabsorbed to coupled of calcium in a paracellular way, and there is a protein claudin 19 and claudin 16 help this paracellular reabsorption from the limb of loop of Henle. CLDN16 mutation and CLDN19 mutation give rise to familial hypomagnesemia with hypercalciuria. And I have already mentioned the Helix syndrome, where the CLND10 mutation causes gain of function of the claudin 10 complex gene, give rise to Helix syndrome, where the increased magnesium reabsorption give rise to hypermagnesemia. This excellent study by Rajiv Sinha and his team, they explored the genetics by doing whole exome sequencing in the East India tubulopathy gene study published recently in Pediatric Nephrology Journal. And they included the index 77 tubulopathy cases which underwent the whole exome sequencing. And they confirmed genetic diagnosis 54. Among them, most prevalent tubulopathy is distal renal tubular acidosis. You can see the number is 25. And they found the positive genes is ATP6V0A4, ATP6V1B1, and SLC4A1, which they described in previous literature. They also found in this Asia region, that is a WDR72 mutation, which associated with amilogenesis imperfecta. And then next to the distal tubular acidosis, Bartter syndrome is the second commonest. And they found chloride channel mutation, KCNG1, SLC12A1. And also they found SLC12A3, which is Gitelman syndrome, though they didn't suspect the Gitelman, but in the Bartter syndrome, they found the Gitelman mutation. And the proximal tubular dysfunction, they found mostly CTNS gene, that is cystinosis, then FAH, OCRL low syndrome, and this Fanconi-Bickel syndrome. And in nephropathic diabetic insipidus, they found only AVPR2, no AQP2 by mutation. Till now, more than 50 genes have been identified for the inherited tubulopathy, and genetic confirmation is required not only for counseling but also for treatment. And as well, and we can go for single gene sequencing or whole exome sequencing. It certainly depends what we are suspecting and what is the local availability and affordability. Nowadays, the whole exome sequencing is the increasingly used as first-line approach. Over past decades, the management of tubulopathy has not changed so much. And the mainstay of management is replacement of water and electrolyte. And if patient presented with acidosis, then we need to correct the acidosis. And if patient presented hypercalciuria and chance of nephrocalcinosis, then we make sure the patient is taking adequate fluid, and we have to give supplementation of citrate. And regarding hypertension management, it should be disease specific. As for example, in Liddle syndrome, amiloride or spironolactone is a drug of choice, whereas in Gordon syndrome, the drug of choice is thiazide diuretics. In Bartter syndrome, prostaglandin inhibitor, that is indomethacin, is drug of choice and beneficial than the Gitelman syndrome. So most of the tubulopathy, inherited tubulopathy, would have better kidney function if we could repair the defect genetically. So far, clinical trials of gene editing mostly addressed hematological and immunological disorder, but fortunately, the advancement of gene editing technologies create a window for the treatment of inherited tubulopathy. But the key obstacles still now remains the targeted delivery of the gene editing machinery to the kidney. In a nutshell, the clinically tubulopathies can presented in various ways, in various phenotypic features and in distinctive features. And blood test and biochemical test is the first line approach for the suspecting tubulopathy. And genetic test is important for the diagnosis and establishment of treatment specific therapy as well as counseling. And management is always multidisciplinary and focused on replacement of electrolytes, adequate nutrition to address the growth failure. So I would like to stop here. Thanks for patience hearing and for sorry for the technical glitch. Sorry.
Yeah, thank you so much, Dr. Azmeri. This was so excellent. You simplified the talk so much for us, the way you explained the genetic part and then the clinical presentation. That was really, really helpful. So thank you so much. The questions can be put in the chat box, and we will address all those questions at the end of the second talk. So I would request all the attendees to please put the questions in the chat box, and we can have a discussion later on. So moving on to the next speaker, I would like to introduce Dr. Prasad Devarajan. He doesn't need any introduction. We know that. He is a professor of pediatrics, endowed chair at University of Cincinnati, USA. He is also the director of nephrology and hypertension, and also medical director of the Stone Clinic at Cincinnati Children's Hospital. Dr. Devarajan has published more than 300 articles, 70 book chapters, and delivered more than 200 invited lectures internationally. He has been continuously funded with National Institute of Health in the last 3 decades. He has been consistently titled in the Thomson Reuters World's Most Influential Scientific Minds. I'm going to say that again, World's Most Influential Scientific Minds. And he has been ranked as top 1% of researchers for most cited publications in the entire field of medicine. This is amazing, sir. Dr. Devarajan has been also the pioneer in investigating biomarkers in AKI. We have all heard about NGAL. I can say that, when I first came to USA, I heard his lecture 15 years ago. It is still fresh in my mind, and NGAL has become so popular all throughout. So again, thank you for your research, and thank you for all the lab that or your lab does in Cincinnati. It is my deepest honor and privilege to welcome Professor Dr. Devarajan for his lecture. Thank you so much for coming and sharing your experience with us, sir.
Well, thank you, Dr. Jain, and thanks to all of you that have joined us today. Let me make sure I can share my screen. Can you see it?
Not yet. Yep, we can see it now.
Okay, wonderful. So again, thank you all. This is going to be a very simple clinical overview of pediatric kidney stones. This is a huge topic, but I'm going to try and make it just quite simple, mostly for the residents and trainees. And then we'll be happy to answer questions as we go along. And what I'm hoping to do today is, I can get the slides to advance. There we go. So we're going to start with understanding the epidemiology, specifically of pediatric kidney stones. And then we're going to talk briefly about clinical features, diagnosis, acute management, prevention of recurrence.
Sorry to interrupt, sir. Can you put it in slideshow?
I thought it was on slideshow. Let me go back.
It is on slideshow. I think it just needs to come as full screen. We can see your next slide at the simultaneously as we see your current slide.
I see. Okay. How about now?
It's the same.
How about now?
I think you just have to tap on, double tap on the bigger screen slide.
Double tap.
Slides are moving. Oh.
Huh. Sorry about that.
That's fine.
Usually my very efficient secretaries tell me what to do and I just do what they tell me to do. And now?
No, I think it should be fine
I
presenting.
think it should be okay.
Yeah, it's fine.
It's
It's
fine.
mainly
You
for the
think so?
recording purposes. We need the complete slides. Otherwise, we can easily see your slides.
Okay, well, let's try this again. So we'll start really with the fact that the incidence of pediatric kidney stones is really very, very high. It's about 1 in 1,000 children and adolescents. Kidney stones are diagnosed in about 1 out of 685 pediatric hospitalizations. So you can imagine how common it is. And the incidence has really increased at an alarming rate by about 5 to 10% every year for the past 20 years or so. And the reasons are really unclear. It's associated with increasing prevalence of obesity, increasing sodium intake, decreasing water intake, and perhaps increased awareness. But these are just associations. This is not a cause and effect. But clearly, we're seeing more and more and more kidney stones. And that's why about 10 years ago, we actually started a dedicated stone center here in my institution. It affects children and adolescents from all age groups, but the highest incidence is seen in adolescents. Both genders are affected, but we've noticed that boys are more commonly affected in the first decade of life. That's probably because of increased incidence of common obstructive urinary tract malformations. But girls seem to be affected more in the second decade of life, likely due to increased rate of UTIs. And I'm going to try to convince you that there is a very strong association between UTIs and crystals and kidney stones, something that has become apparent in the recent few years. This is the problem. Pediatric kidney stones recur. They recur and recur and recur. About 50% of children will have a recurrence within 3 years of an index stone. And we have some data recently showing that almost 100% will recur within 4 to 5 years. So the recurrence is a big problem in pediatric kidney stones. And it's most common in the younger children because they have the highest incidence of metabolic, genetic, and urinary tract abnormalities. There's a problem with these recurrences. They are, of course, associated with pain, missing school, missing activities, headache for the parents, increasing clinical costs, and again, a very important teaching point here, development of chronic kidney disease. We've all had patients with recurrent kidney stones who have gone on to need dialysis and transplantation just because of recurrent kidney stones. And the best proof of that is from this picture here that I'm showing you. These are 3 kidney biopsies from patients who had recurrent kidney stones. And if you can go from the right to the left, on the right-hand side, you can see already that there is a fair amount of tubular interstitial damage. And as you go from right to left, the amount of fibrosis and interstitial damage and atrophy increases. Now, these are 3 patients who had kidney stones, and that's it. They did not have any primary or any other kidney disease. So take-home message is there are important chronic kidney disease consequences of recurrent kidney stones, especially in children. And that's why we need to take it very seriously. What forms these kidney stones? We all know that it's mostly calcium oxalate, calcium phosphate, or mixed calcium oxalate and phosphate. There are some rarer causes in children, the infectious or struvite stones, cystine, and uric acid. And there are some even more rare causes like primary hyperoxalurias. But the bulk of kidney stones are either calcium oxalate or calcium phosphate or mixed calcium oxalate and phosphate. And recent evidence has shown that most kidney stones in children start as calcium phosphate, making what's called as the Randall's plaques. And then on top of that calcium phosphate, we get calcium oxalate deposition. So when it comes to treatment of calcium stones, one needs to address both the phosphate and the oxalate problem. Risk factors. Why do kids get so many kidney stones? An underlying risk factor can be identified in about 90% of cases. And that makes it very important for us to look very diligently for the underlying cause and not simply dismiss it as, okay, that's just another kidney stone. And out of all those risk factors, about 50% is because of a urinary metabolic abnormality. Specifically, we're talking about either too much solute, specifically calcium oxalate, uric acid, cysteine, or just not enough water. If there's not enough volume, even normal amount of solute will get supersaturated. And the other important reason is decreased inhibitors of stone formation. The reason why we all don't get kidney stones, even though we all have calcium in our kidney, the reason we don't get kidney stones is because there are very powerful endogenous inhibitors of stone formation. And the two best studied ones are citrate and magnesium. And the way that works, of course, is that even though if we have a lot of calcium in the kidney and in the tubules, if there is enough citrate, the calcium will bind to citrate and that forms a soluble complex and we just pee it out. But if there's not enough citrate, even normal calcium in the kidney can cause supersaturation with oxalate and phosphate. So that's 50%. The other 25% is because of renal or urinary tract structural abnormalities. And those structural abnormalities lead to urinary stasis. Stasis leads to crystals, and stasis leads to infection, and all of that leads to kidney stones. And the final 25% is just UTIs, with or without the above two. And this is, again, a recent recognition that just recurrent UTIs are a very important cause of recurrent kidney stones, especially in children. So let's look at each of these risk factors very briefly, and we'll start with urinary metabolic abnormalities. And many of these have already been addressed by Dr. Azmeri, and so we'll briefly go over that. So it's either hypercalciuria, hypocitraturia, hyperoxaluria. Those are the most important solute causes. And of course, all of those are confounded by low water intake and low urine volume. And the recent trends have shown this dramatic increase in the detection of hypocitraturia. We don't know why. It's probably dietary, it's probably genetic, we're not sure. But traditionally, we used to think hypercalciuria is the most important metabolic risk factor. But now it is becoming obvious that about 70% of children with kidney stones actually have low levels of citrate in the urine, and that is the primary cause that leads to the risk factor of kidney stones. Briefly look at each of these. Hypercalciuria, like I said, historically, that was the most common cause, not anymore. This is what we teach, urine calcium greater than 4 milligrams per kilo per day, or calcium to creatinine ratio of 0.2. So if we cannot collect a 24-hour urine, we can do just a spot urine and get a calcium creatinine ratio. And anything more than 0.2 is not normal in children or adults. But there is, just to remember, there is a normal, the normals vary with age, so that by 5 to 6 years of age, we should have reached the adult normal value of less than 0.2. But the younger the child is, the higher the urine calcium creatinine ratio is, and it is still normal. So the range is 0.8 to 0.2, but typically we ask our residents and fellows to remember 0.2. What causes hypercalciuria? There are physiologic mechanisms that are very clearly delineated. It could be absorptive, meaning too much absorption from the intestines. Or it could be renal leak, meaning too much leak from the kidney. Or it could be resorptive, meaning excessive calcium resorption from bone, leading to hypercalcemia and hypercalciuria. We'll briefly look at each one of these: absorptive, renal leak, and resorptive. Increased intestinal calcium absorption. What causes that? Most of the time it's idiopathic. And that means I'm an idiot and I don't know what the cause is. But people like Dr. Sultana can probably do a good genetic analysis and tell you what the cause is. But it's mostly idiopathic. There are specific genetic disorders, and Dr. Sultana told you about some of these. And there are some other important dietary factors to consider. Vitamin D excess, calcium supplements, important cause of absorptive hypercalciuria, of course, hyperparathyroidism, and any other cause of hypercalcemia, be it tumors, be it anything else. All of this will lead to absorptive hypercalciuria. The renal leak is defective renal tubular calcium reabsorption, and that leads to hypercalciuria. And this is actually the most common cause of hypercalciuria. And again, the underlying cause is idiopathic. There's almost certainly a lot of genetic components to it, and we're only beginning to understand some of those. And there are some specific genetic disorders, many of which Dr. Izmir already talked about. Important to remember a couple of medications: loop diuretics, not thiazide diuretics. Loop diuretics like furosemide and acetazolamide are important causes of renal leak hypercalciuria. High animal protein diet, ketogenic diet, and hyperparathyroidism rounds up the other common causes of renal leak hypercalciuria. And finally, resorptive. There's enormous amounts of calcium in bone, and when there's excessive calcium resorption from the bone, that leads to hypercalcemia and hypercalciuria. And the number one cause there, of course, is prolonged immobilization. Many of our children who are afflicted by serious neurologic disorders are largely confined to being immobile. Those are the ones that get recurrent kidney stones. We call them stone factories. They just keep getting kidney stones, and it's because of prolonged immobilization leading to excessive calcium resorption from the bone. Glucocorticoids can do it, and there are some, again, rare genetic causes that can do it. But by far, the most common cause of resorptive hypercalciuria is prolonged immobilization. What about low citrate? I began telling you about it, now emerging as the most common metabolic abnormality in pediatric kidney stones. And that is the normal range. And again, we can do spot samples. You don't need a 24-hour urine. And what we teach is normal citrate levels should be greater than 0.25 milligram per milligram creatinine in a spot urine. What causes hypocitraturia? We're not totally sure, but we know that citrate is a naturally occurring inhibitor of calcium oxalate and calcium phosphate crystallization. Citrate binds to calcium in the tubular lumen, and it forms a non-dissociable but beautifully soluble complex that is easily excreted, and we just pee it out. So even if the calcium level in the tubular lumen is high, if your citrate level is normal, you don't get kidney stones because you don't have enough calcium there to combine with oxalate and phosphate. Remember, calcium oxalate and calcium phosphate are insoluble, and they deposit as crystals and stones, whereas calcium citrate is beautifully soluble, and we just pee it out. Idiopathic, most likely. We don't know the cause in most cases of hypocitraturia. There are well-defined dietary citrate deficiencies, patients with chronic metabolic acidosis from any cause, including many of the diseases that Dr. Izmir talked about. What happens in metabolic acidosis is that you get increased proximal tubular reabsorption of citrate. And as a result of that, there is not enough citrate in the distal nephron, and that's what causes calcium phosphate. And on top of the calcium phosphate, you get calcium oxalate. Two important medications that cause chronic metabolic acidosis, carbonic anhydrase inhibitors, topiramate and zonisamide, very commonly used anti-epileptic agents. And the majority of patients who are on these medications get recurrent kidney stones. Ketogenic diet, another common treatment for refractory epilepsy, high animal protein, all causes of hypocitraturia. But again, most of the time, we don't know the actual cause. Hyperoxaluria, very briefly, hyperoxaluria itself can be found in 10 to 20% of children with kidney stones, but that doesn't mean they have primary genetic hyperoxaluria. Primary hyperoxaluria is a very rare disorder, but having hyperoxaluria as a contributor to even regular calcium kidney stones is not uncommon. And those are the normal spot urine oxalate to creatinine ratios. Again, it varies with age, but what we teach is if you're more than 6, your ratio of oxalate to creatinine should be less than 0.06. What causes hyperoxaluria? I know, same thing, idiopathic, idiopathic, idiopathic means we don't have all the possible genetic diagnoses for hyperoxaluria, just like we don't have for hypocytituria and hypercalciuria. But something causes increased intestinal oxalate production or increased intestinal oxalate absorption. And one important factor is dietary calcium deficiency. A very common response to kidney stones is, oh, it's mostly calcium containing stones, so let's restrict calcium intake. Big mistake. Big mistake, because when you restrict dietary calcium intake, there is not enough calcium to bind to oxalate in the gut. Oxalate is present in a large number of the foods that we eat, so that leads to free oxalate, and that gets reabsorbed, it goes to the kidney, and they form calcium oxalate stones. So please do not restrict calcium in children with kidney stones. Another important reason is fat malabsorption. Same concept. When you have fat malabsorption, you have excessive fatty acids in the gut, and fatty acids very tightly bind to calcium, and they lead to a local gut calcium deficiency. And that again leads to excessive free oxalate, and that gets absorbed. So important fat malabsorption syndromes are seen in patients with bowel resection, inflammatory bowel disease, all forms of pancreatitis, and cystic fibrosis. A couple of medications. Everybody in the COVID era is taking excessive vitamin C supplements, and we're seeing a lot of kidney stones from that. And that's because, as you all know, vitamin C is directly metabolized to oxalate in the liver, and that leads to excessive oxalate in the blood and in the kidney. And there are, like I said, very rare causes, genetic causes, primary hyperoxalurias, type 1, 2, and now 3. And those are specific mutations in the liver cell that that causes excessive oxalate excretion from the liver. Just very quickly about hyperuricosuria. Yes, mostly idiopathic. But there are some syndromes we should be aware of that cause overproduction of uric acid. And you all know about tumor-lysis syndrome, lymphoproliferative and myeloproliferative disorders, and the very rare Lesch-Nyhan syndrome. But overall, hyperuricosuric kidney stones are not common at all in children, although they become more common in adults. And some rare glycogen storage disorders all can cause hyperuricosuria. So those are all the big metabolic problems: excessive calcium, low citrate, excessive oxalate, and in some cases, excessive uric acid. But then what about the structural factors? So patients with medullary sponge kidney, polycystic kidney disease, horseshoe kidney, UPJ obstruction, neurogenic bladder, and bladder augmentation. All of these patients have a problem that leads to urinary stasis. And when there's stasis of urine anywhere, that leads to supersaturation and crystal formation, and therefore stone formation. And that is why all of these conditions are associated with recurrent kidney stones. And finally, infections. Urinary tract infection may be the primary cause of a kidney stone, or may occur along with a structural abnormality or along with a metabolic abnormality. But like I said before, just recurrent UTIs is now becoming apparent as an important cause of recurrent crystals and kidney stones. Now, of course, like I said, any anatomic or any functional obstruction of the urinary tract will lead to stasis, infection, and stone formation. But when we talk about infections, there are a couple of specific infections that I want to briefly tell you about, and that is Klebsiella pseudomonas proteus. These are urease-producing bacteria, and they will break down urea, which is normally present in the kidney and kidney tubules. And breaking down urea will form bicarbonate and ammonium, and that leads to ammonium phosphate magnesium stones, also called as struvite stones. And the problem with these stones is they can enlarge to fill the entire kidney, and that's called the Staghorn calculus. And so these specific bacteria, Pseudomonas Klebsiella proteus, will can lead to staghorn calculi, but the usual bacteria like E. coli usually lead to smaller kidney stones. I want to show you a couple of pictures. This is on the left side, a KUB or a plain X-ray of the abdomen. And you can see two huge kidney stones. These are staghorn calculi. And on the right-hand side, you can see when one of those kidney stones was removed, and you can see it's almost 13 centimeters. And that's basically the size of a pediatric or young adult kidney. So the entire kidney was occupied by the staghorn calculus. Let's now look at the clinical features. And there are some important differences between adults and kids that I'd like to illustrate. Yes, classically, we talk about pain and flank pain or renal colic. But more than 50% of children with kidney stones actually present with abdominal pain, and not so much with back pain or flank pain. They present with abdominal pain, and there is an incidental ultrasound or X-ray done for that, looking for constipation or something else, and we find kidney stones. So abdominal pain is an important clinical feature for pediatric kidney stones. And the younger the child is, the more likely they will complain of abdominal pain rather than the classic renal colic flank pain. About 50% will present with just gross hematuria, with or without abdominal pain, with or without back pain. So when there's recurrent gross hematuria, an important thing to consider is kidney stones. And some will just present with no back pain, no hematuria, but just UTI symptoms. Dysuria, frequency, urgency, and we believe that that is because of the crystalluria. As you have these crystals traveling down the urinary tract, and the child trying to excrete this high crystal load, that leads to dysuria, frequency, urgency. Even after avoiding, there is some urine left over in the external genitalia, and the fluid part will evaporate, but the crystals will stay there, and these kids will want to go to the bathroom all the time. So the gut response is, oh, this is probably a UTI, or this is probably behavioral. No, please look at the urine, and if you find crystals, this is your classic case of crystalluria, and if we don't treat it, that child is going to get kidney stones. Nausea and vomiting can be present if the stones are obstructing. Again, typical adult renal colic is flank pain, nausea, vomiting. Doesn't happen in kids unless the stone is really obstructed. And about 20% of pediatric kidney stones are detected incidentally. There could be a sports injury and there might be some microhematuria. We do an X-ray or an ultrasound and we see kidney stones. So the importance of looking at the urine cannot be overestimated. And this is an example of what calcium oxalate crystals look like in the urine. In the middle, you're looking at the typical dihydrate form, which is the beautiful envelope-shaped diamonds. This is the most common form of calcium oxalate crystals. On the left and on the right, we're seeing the two monohydrate forms, the dumbbell shape as well as the needle shape. And the importance of this is the dihydrate crystals lead to kidney stones that can be are easily crushed or are soft, whereas the monohydrate stones are very, very hard. And it's very difficult to treat those stones with things like extracorporeal shockwave lithotripsy. So very important to look at the urine to figure out what the crystals are, and even within calcium oxalate, what type of calcium oxalate crystals. So these are what calcium phosphate crystals look like. They're pleomorphic, they're this star-shaped, again, if we see most of this without calcium oxalate, it tells us to address the phosphate issue and not so much the oxalate issue. And these are some of the rarer causes. Cystine, hexagonal crystals, very important to diagnose. A rare condition, but earlier we diagnose it, the earlier we can treat it. So this is very classic, and it's there in every board exam, and every exam you'll see a picture of this and they'll ask you for the diagnosis. Uric acid crystals are pleomorphic, and the infectious struvite stones lead to these coffin-shaped crystals. So very important to look at the urine under the microscope. And you don't need a fancy microscope. This is just simple 40x microscopes. Imaging is a very important modality for confirming the diagnosis. Unless the patient comes to you with a kidney stone that he or she has passed and you do a stone analysis and it's a stone, the only way to confirm the diagnosis is imaging. And it's also required for ruling out obstruction and to look for any urinary tract abnormalities, structural abnormalities that increase kidney stone risk. And we can do ultrasounds, we can do non-contrast helical CTs, and we can do plain radiography. Very briefly to go over these imaging modalities, the preferred modality is ultrasound. And it's usually the initial imaging modality of choice, and we strongly recommend that. Why? Because it's usually easy to perform, it's reasonably widely available, it's relatively inexpensive, it's quick, there is no harmful radiation. Remember, these kids get recurrent kidney stones, and we don't want to do recurrent CT scans on these patients because the radiation exposure will increase with time. And ultrasound can detect both lucent as well as opaque stones and can detect obstruction and urinary tract abnormalities. So what's the disadvantage of ultrasounds? It may miss the small stones. So stones that are less than 5 millimeters or stones that are hidden somewhere in the calyx or the ureter, we may miss it by doing an ultrasound. And the sensitivity, when we look at the ultrasound for all kidney stones, small, medium, large, is about 70% compared to CT. CT is almost 100%. But an ultrasound will pick up more than 90% of stones that need surgical intervention. And the specificity is 100%. If you see a kidney stone by ultrasound, that's what it is. And there's no mistaking it. I'll show you a couple of pictures of what ultrasound looks like for kidney stones. So on the left, you're seeing the combination of echo density with acoustic shadow. So the echo density is the dense stuff that you're seeing in the kidney. And then what you're seeing below that is the acoustic shadow. And it's important to see both the density and the acoustic shadow to be confident that it's a kidney stone. Kidneys can have a lot of reasons to have echo densities. It could be a blood vessel, it could be a lymphatic, it could be a lymph node, it could be anything. But if you don't see the acoustic shadow, we don't call it a kidney stone. And on the right-hand side, you can see what happens when we turn on the Doppler. We see this beautiful twinkling artifact. So there's the kidney stone and there's the artifact below it with twinkling. And so the combination of acoustic shadow and twinkling artifact pretty much is 100% diagnosis of kidney stone by ultrasound. So what about CT scans? A lot of people prefer CT scans, especially adult urologists and nephrologists. And the specific CT scan we talk about is not a regular full contrast CT scan. This is a non-contrast, low-dose helical CT, and that's the most sensitive imaging modality. Sensitivity is close to 100%. It's quick, 2 minutes, easy to perform, nearly 100% sensitivity and specificity, and it's especially sensitive for the small stones and the ureteral stones. Remember, stones that are less than 5 millimeters, we may miss by ultrasound, but you will always pick it up by CT scan. And it can also detect abnormalities. Well, it is expensive, and there is, like I said, increased exposure to harmful radiation, especially in our children that get recurrent kidney stones. And so in our opinion, I think CT scans should be reserved for cases where the ultrasound is non-diagnostic. Patient presents with symptoms of kidney stones, the urine shows crystals, ultrasound shows nothing. What do you do? So then you might want to get a CT scan because they could have a small kidney stone that we're missing by ultrasound. Or if the symptoms persist and there's no explanation for it, we will sometimes get a CT scan. And this is what our kidney stones look like on a CT scan. On the left-hand side, you can see small to moderate sized kidney stones on both kidneys. And on the right-hand side, you can see fairly large kidney stones on both kidneys. Finally, plain X-ray. Sometimes ultrasounds and CT scans are not available, especially in some low resource areas. It's easy to perform, but and there's minimal radiation and inexpensive, but it can only detect radio-opaque stones like calcium, cysteine, and struvite. We will miss radiolucent stones, which luckily in pediatrics are rare, but that is a problem, that we will miss uric acid stones by just doing a plain X-ray. And of course, we cannot detect urinary tract anatomic abnormalities or obstruction. And again, we may miss small stones or the ones that overlay the pelvis or other bony structures or the spine. But if you don't have anything else, a plain X-ray can be good because, for example, here on the left-hand side, you can see a kidney stone in the lower pole. And on the right-hand side, you can see a staghorn calculus on one side and multiple calculi on the other side. Acute management, patient presents to you. What do you do urgently? That really depends on how severe the pain is and whether there is obstruction or whether there is infection. Those are the deciding factors in terms of acute management, but most of them can be managed medically. We very rarely call a urologist for an acute kidney stone. And the medical management is pain management, hydration, and alpha blockers. And we do all that while we await for the stone to pass. When do we call the urologist right away? When we suspect obstruction, when there is acute kidney injury, when the pain is not manageable with medications, or when there is infection. Those are the usual reasons why we would request an urgent urologist to see the patient. Most patients can be managed medically, and most patients can be managed as outpatient. We very rarely admit these patients to the hospital, except if they have obstruction, if they have infection, if it's a solitary kidney with a kidney stone, or if the patient cannot eat or drink and needs IV fluids and IV pain medications. Those are the reasons to admit the patient. Otherwise, mostly it is outpatient management. Hydration is the cornerstone of management. It will correct any dehydration. It will correct any supersaturation of crystals. It will prevent acute kidney injury. And we think it facilitates the passage of the kidney stones. Most patients with symptomatic renal colic will require some initial IV hydration and antiemetics, but that doesn't need to be hospitalized. They can get that as an outpatient. Pain control is very important. Kidney stones are very painful. And so most patients with symptomatic bad kidney stones will require initial IV analgesics, and we prefer to use narcotics like morphine. We try not to use NSAIDs because NSAIDs, as you all know, can worsen acute kidney injury. And so if we're going to use NSAIDs, especially as outpatient, we want to make sure that the patients remain very, very well hydrated. Retrieval, the gold standard, right? So we tell the patients to strain the urine. We give them a little strainer, like what you use to strain tea. And we tell them to pee in the strainer and collect any fragments that come out. And when the stone is retrieved, we send it for a direct analysis to determine the composition. That is the gold standard. What is causing the kidney stone? Analyze the kidney stone. But frequently, the patients do not catch them, or if no stone is recovered, then we do follow-up imaging just to make sure that the stone has been passed and the patient just missed it. There is now very good evidence for medical expulsive therapy in children. So most ureteral stones, if the stone is already in the ureter, especially the distal half, and if it's less than 5 millimeters, we can be pretty confident that it will pass spontaneously. And that patient just needs fluids, hydration in the acute phase. But if the stone is larger, typically 5 to 10 millimeters, and many of our stones are in that range, 5 to 10 millimeters, or those that do not pass with just fluid management, they are good candidates for medical expulsive therapy with alpha adrenergic blockers. And the rationale for that is that the lower half, or the distal 1/3 of the ureter and the ureterovesical junction respond very well to alpha blockers by relaxing the smooth muscle. And so there is now very good evidence. There are 4 or 5 papers published that show that using tamsulosin, which is an alpha adrenergic blocker, also called Flomax, is very good for pediatric kidney stones, especially in that 5 to 10 millimeter range. So if it's less than 5, we usually don't use it. 5 to 10 millimeters, we use it. Even slightly higher stones, if it's in the ureter, there is good evidence that this works. So it is safe, it is effective, and we use it for children all the way down to 2 years of age. It is off-label, but we use it. The dose is 0.2 milligrams for children between 2 to 4 years of age, and 0.4 milligrams for any child greater than 4 years of age. Stone passage may take several weeks, and we usually confirm it either by the stone retrieval or by getting an imaging. And it's a capsule. It can be opened and sprinkled onto any food for even young kids who cannot swallow pills. So it's a very good, convenient way, and reasonably effective, reasonably inexpensive, but it's still off-label. But we use it. The only potential side effect we tell the family is orthostatic hypotension. So if the child starts complaining of dizziness, or when they wake up from bed, they feel dizzy, then that's the time to stop the medicine. When do we need surgical therapy? About 20% of acute kidney stone episodes will require surgical intervention. And like I said, the surgery without even a trial of medical therapy is conducted when there is complete obstruction, solitary kidney obstructed, any obstruction complicated by infections, severe pain, and symptomatic stones that fail to pass after medical therapy. We usually try for about 4 weeks with pain medications, fluids, medical expulsion therapy. And if the stone doesn't pass and the patient remains symptomatic, we will need to consider some kind of urologic intervention. So what do urologists do? The most common surgical modality is to actually do a ureteroscopy with laser lithotripsy or stone extraction. So it's directly passing a scope into the bladder, into the ureter, into the kidney pelvis, pulling out the stone. If necessary, if the stone is too big, we can do a laser lithotripsy and break down the stone and get it out. That's the most common thing we do in children. Adults, mostly we do extracorporeal shockwave lithotripsy. And finally, large stones will of course require a open percutaneous nephrolithotomy. And really the choice of which one we do will depend on the local surgical expertise, availability of equipment, the size and anatomic location of the kidney stone, and etiology of the kidney stone. For example, stones that are in the ureter and are small, 5 to 10 millimeter size, we prefer ureteroscopy. Stones that are lodged within the kidney, which we cannot reach by ureteroscopy, those will need extracorporeal shockwave lithotripsy, which is safe in children, but we try to reserve it for symptomatic stones that are sitting inside the kidney, which we cannot access by ureteroscopy. And the etiology is important because, like I said, monohydrate calcium stones as well as cystine stones are very, very hard. And it's very difficult to do extracorporeal shockwave lithotripsy for those stones. And so cystine stones, struvite stones, typically we will do open nephrolithotomy. The bottom line is it all depends on the local availability of equipment and local surgical expertise. So kidney stones constantly recur, and that's because they have risk factors. So how do we evaluate for those risk factors? After an acute episode, after the patient has passed the stone, is asymptomatic, all children absolutely should be evaluated for risk factors that promote kidney stone formation. And this includes a direct analysis of any retrieved stone, if we're lucky enough to get a stone, and a comprehensive metabolic evaluation of blood and urine. And like Dr. Azmiri said, consider genetic testing in these patients, especially the ones with recurrent kidney stones. So how do we prevent them from happening in the future? Fluid is the gold standard. And this is what we tell our patients, children less than 5 years, need to drink at least 1 liter per day, 5 to 10 years, 1.5 liters per day. And any child above 10 years should drink a minimum of 2 liters per day. Adults, we tell them 3 liters per day. We tell them to limit their dietary sodium intake. When we take in excessive sodium in the diet, that gets excreted by the kidney, and that drags calcium with it and causes local hypercalciuria. We tell them to maintain a normal dietary calcium intake because we do not want them to have low calcium levels in their gut, which will lead to oxalate reabsorption. Good luck with this. Avoid excessive animal protein diet. And we normalize vitamin D status because excessive vitamin D can cause excessive absorption of calcium from the gut. So if we detect hypocituria, in addition to all those measures, what else do we do? We tell them to increase potassium-rich fruits and vegetables. Potassium is a very good endogenous inhibitor of kidney stones. And if you don't have enough citrate, at least supplement them with potassium. We tell them to increase the dietary citrate, which is citrus fruits, fresh green leafy vegetables, and lemonade is a very, very good source of citrate. And then we, depending on the degree of hypocituria, we will frequently supplement them with potassium citrate supplements. And the dose is 2 to 4 MEQs per kilo per day and is usually given in 3 divided doses. And we give it with meals to prevent GI irritation. If you give potassium citrate on an empty stomach, that is going to cause GI irritation. And in fact, we've had patients who had some gastroparesis and were not eating and were still taking the citrate and actually led to ulcers and even perforation. So potassium citrate is a very benign medicine. It's just a supplement, but it should be taken with food or after food. Luckily, it's available as a liquid, as a powder, and as pills, so most children can take it without problems. What about hypercalciuria? What additional measures can we do? Typically, we treat them like a hypocituria, and we first start treatment with potassium citrate supplements, even if it's hypercalciuria. Because like I told you, if you increase the amount of citrate in the kidney, even if you have high levels of calcium, the calcium will bind the citrate, it's soluble, we'll pee it out, end of story. But if the hypercalciuria persists, we use thiazide diuretics, and not loop diuretics, but thiazide diuretics. And that's chlorothiazide or hydrochlorothiazide, whichever one is available. And of course, the way that works is it creates a local sense of dehydration, and that promotes proximal tubular reabsorption of calcium and decreases hypercalciuria. But we all know that the side effect is hypokalemia. Patients with hyperoxaluria specifically, we decrease the dietary oxalate. These are the important high oxalate content in the diet. We stop vitamin C, we give them potassium citrate, we give them magnesium supplements, and we give them empiric pyridoxine if we suspect primary hyperoxaluria. And in these two rare cases, cystinuria, potassium citrate, and a very specific medication called thiopronin, which binds cysteine and again forms a complex. And in patients with hyperuricosuria, citrate and allopurinol, which decreases production of uric acid. So that then is, in a very, very short nutshell, a very brief clinical overview of kidney stones. And I hope I've convinced you that the incidence of pediatric kidney stones is very high and it's rising in front of our eyes. It's associated with high morbidity, high cost, and perhaps most importantly, with the development of chronic kidney disease. The risk factors are either metabolic or structural or infectious. Recurrence is very common. But luckily, we now have pediatric specific approaches for the treatment of not only the acute episodes, but also to prevent recurrence. I thank you for your attention, and I'm happy to answer any questions.
Thank you so much, Dr. Devarajan. This is such an excellent talk, and you have simplified so much for us how to approach pediatric kidney stones. And as you mentioned, we are all seeing more and more of pediatric kidney stones. And I think the simplified approach helps us a lot in managing it. And with that, I would open the session, and I would request Dr. Sampath to take charge with the question answer session. I would also like to mention that Dr. Namalwar has been with us. He joined just a few minutes after we started the session. So Welcome, Dr. Namalwar, and thank you for joining. And we would appreciate all your input as well.
Thank
Over
you.
to you,
That
Dr.
was,
Sampath.
yeah, thank you. That was an excellent session where the basics of pathogenesis of nephrolithiasis and also how to manage the common causes of renal stone disease were beautifully described. So my own question is about the analysis of the stone composition. Gone are the days that the stones are extracted in toto and given it to the patients and also for the doctors. Nowadays, we have come to the era of pulverization and also laser lithotripsy, where the stone composition is difficult to get. So how do you assess the modern, what are the modern methods of this assessment? In our own hospital, we have this X-ray crystallography. To some extent, it is able to tell us, but there are some blind spots, like it may not be able to tell us about the protein composition. It may be able to give us the crystals, but your thoughts on that, Professor Devarajan?
Yes, you are absolutely correct. So what the stone analysis is done by commercial labs, and it's a send out, and we send it out and we get the result in about 2, 3, 4 weeks. And typically what they do is determine the mineral component. So they'll tell us if it's calcium hydroxyapatite, calcium oxalate, calcium phosphate. They will not tell us if it is cysteine, for example. So it's the mineral content that we can reliably get. And what they ask for is a stone of at least 2 millimeters in size. Yeah. If it's a tiny fragment, they'll say, we cannot do it. So that limitation still exists. If we see cysteine crystals in the urine, then we actually send it for a 24-hour urine cysteine measurement. And that's a different technology and has nothing to do with actual stone analysis.
The other question is how far have been successful in use of this B6, the pyridoxine, in cases of possible primary hyperoxaluria, and what has been your experience in that?
Yeah, so if we see evidence, clinical evidence for primary hyperoxaluria, and you're talking about the genetic variant, we will empirically start pyridoxine, high dose pyridoxine. And the success rate is about 50%, honestly. And it depends on whether it's type 1 or type 2 or type 3. Yeah. Type 2 and type 3 do not respond to pyridoxine. Yeah. Certain genetic mutations underlying type 1 primary hyperoxaluria will respond, at least for a few months or a few years. So it gives us a little bit of time to plan the additional therapy. But nowadays, the treatment of primary hyperoxaluria has dramatically changed, at least in the developed countries, because once we get the genetic diagnosis, which takes 2 weeks, we put them all on RNA inhibitors, the lumasiran or nedosiran, and that is very effective, extremely effective. We have a number of patients, and this has been published in the literature. It's an injection, subcutaneous injection that is given once every 3 months. It's given by the family at home. Extremely effective, at least in the 2 to 3 years that we've been using it so far. Yeah. So that has been the big revolution in the treatment of primary hyperoxaluria, the availability of lumasiran as an RNA inhibitor. It's an agent that goes and attaches directly to the hepatocyte. The inhibiting RNA gets released into the hepatocyte, and it inhibits the production of oxalate. Beautiful technology, very, very effective.
Yes, sir. Excellent. So there are some questions on the question box. So a question about the calcium creatinine ratio, depending on age, which is 0.8, and the definition is more than 0.2. So I think the definition, as you correctly said in your slide, the 0.8 is for ages below the age of 1, if I remember it right. Above the age of 4, it is always 0.2. It is, isn't it, sir?
That is correct.
Yeah,
Yes.
yeah.
So that's what we teach.
Yeah,
I mean,
yeah,
anybody who is above the age of 4 to 5,
yeah.
ratio should be less than 0.2.
Yeah. And about the association of hyperoxaluria with fruits, as few are supposed to be rich source of vitamin C.
Yes, absolutely. So when we have patients with calcium oxalate kidney stones or calcium oxalate crystals, we will tell them to reduce the oxalate in the diet. High oxalate content in the diet is spinach, rhubarb, strawberries, peanuts, chocolate, and tea, by the way.
Yeah.
Coffee is fine, tea is not fine.
Yeah, I just want to share my own experience of a child again, who had presented with a very severe metabolic alkalosis. We were all thinking that it is Barter's syndrome. Then we went ahead with the investigations, even though there were some outliers like the urinary sodium and chloride was not very high. We were still thinking that it is going to be Barter's. Then we went ahead with the genetic analysis, and then we diagnosed it. It came as a real surprise to us that it was a cystic fibrosis. So, so then our eyes were opened, and then we are able to diagnose a couple of more cases of cystic fibrosis, which is presenting with very severe metabolic alkalosis.
Yes, absolutely. So one
Yeah,
of
I
the
have.
main,
Sorry, Prof. Go ahead.
Yeah.
Go ahead, Dr. Azmiri.
I have already mentioned that sometimes barter and also that pseudo-hyperaldosteronism can present it like cystic fibrosis like feature, because the ENaC channel and also sodium chloride channel may expressed in the skin as well as lung. So it may be sometimes difficult, and for this reason, genetic test is so much helpful for you to differentiate how you should treat the cystic fibrosis, or it is a barter or it is a Gitelman. Thank you, Prof.
Yeah. Anybody else with questions?
I have a question to Dr. Devarajan.
Yes, sir.
Can you go ahead? What the earliest age you like to use those two drugs for oxalosis? Because quite frequently we see newborn children with renal failure and hyperactive kidney. Could you use this drug in those children?
So the FDA has approved the use of lumasiran down to 6 years of age, but there are currently studies that the company is doing to go down all the way to 6 months of age, and there should be no contraindication to it. So if I see a child, for example, who is 1 year old and has primary hyperoxaluria and kidney stones and worsening kidney disease, I will appeal to the company to provide us with the medication on a compassionate basis. And they're pretty good about that. So the short answer, the official answer is 6 years of age, but I think that is going to change unless Amrish knows more than I about this.
No, I think those are the current indications. That's the age that it's being approved for. I mean, definitely the compassionate use does take a lot of paperwork and all. But it can be done, and that's really helpful for the child. I mean, and we can avoid a transplant. I think that's what I feel, that waiting till 6 years, I think that still puts you at risk of ESRD, end-stage renal disease, and starting early, that would be ideal.
My question is, the child who's on need for a dialysis, and an infant who's on need for a dialysis, would you still persist, or you would like to avoid that drug? Would it be able to get back to your improve your renal functions?
Okay, so the studies are ongoing. So there's a clinical study right now looking at children who are already on dialysis with primary hyperoxaluria. Can lumasiran reverse the condition? But there have been published reports of patients who had delayed graft function after a kidney transplant. After a kidney transplant, they went back on dialysis, and those patients were put on lumasiran, and they're now off dialysis. So yes, even when you have dialysis requiring end-stage kidney disease, this medication seems to be able to reverse the problem.
Thank you.
So yes, we actually had a patient who got a kidney transplant for end-stage kidney disease of unknown etiology. And after the transplant, the kidney never opened up. And then we did a biopsy, and the biopsy showed oxalate crystals all over the kidney. And so retrospectively, we made the diagnosis. We got the genetic test. That patient was on dialysis for a while. But then once we got the lumasiran started, the patient came off dialysis after a few months. And is now doing fine.
Do they require it lifelong?
Yes.
Yeah.
Either that or a
Yeah.
liver transplant. Those are the
Yeah.
only two treatments.
The native kidney, if the child is already on transplant, the native kidney can be safe. What you have discussed is about the second transplant. In case the primary disease is oxalosis and the kidneys are all completely have the deposition of oxalate, then can it be retrieved to normal GFR?
That's the clinical study that is currently in progress. I don't know the answer to that, but we should have the answer in the next couple of years.
Okay, fine.
I don't think we have time to go through all these questions. Possibly I'll pick and select a couple of them.
Yeah.
How does the value of metabolic parameters change with worsening renal function? So your calcium creatinine ratio, does it change with lowering of GFR, or is the diagnosis the same? 0.2?
No,
Yeah.
it should not change because it's the calcium to creatinine ratio. So we have the creatinine to help us out with to normalize it. But it's not perfect. As we all know, as GFR drops and CKD progresses, there are changes in the tubular secretion of creatinine. We all know that. And so that can vitiate some of these, but those are small changes. When there's hypercalciuria, it's very obvious. It's 5 times normal. And so it usually doesn't affect our diagnosis.
Yeah. About the question of hydration in urolithiasis, what type of fluid will be helpful? Normal saline, but BP may increase.
So there's nothing normal about normal saline.
Yeah.
Normal saline is not normal. But in the initial phase, you can use lactated ringers, you can use plasmolite, you can use normal saline. But after a little period of normal saline, we try to reduce the amount of sodium in the IV fluids. And we try to give some form of glucose or dextrose. Yeah. So normal saline is not normal.
Yeah, that is a take-home point for the residents. I think we are through with this highly educative symposium on renal stone disease and genetic analysis. I'll leave the rest with Dr. Kalaimani Ganesh. You are muted.
Muted.
We next have the polling session only meant for the trainees. If the panelists are interested in just going through the questions, it's fine. Dr. Amrish.
We don't want to fail. So we would rather be appearing very knowledgeable and stay off. Yeah.
Yeah, this is the 6th and the final session for the polling, and the results will be counted at the end. We will be giving out the results in the next session, which is 17th. 17th, we'll be giving the final results, August 17th. And again, thank you for all the panelists, Dr. Devarajan, Dr. Azmeri, Dr. Sampath. If you would like to stay back, please stay back. But
Yeah.
thank you again for such a wonderful session and sharing all your wealth of knowledge. We really appreciate that. Thank you so much.
Thank you.
Thank you so much, sir, for the enlightening session.
Thank you. Thank you. Great.
Thank you, Asmiri. Thank you, Sampath, sir.
Thank you.
Thank you. Thank you. Bye.
Thank you. Bye-bye.
Bye.
You're staying back for the session, Dr. Amrish?
Sure, I can stay back. You can give the instructions. I can read the questions.
So we'll move on to the polling session now. And so the instructions are the participants are requested to enter the proper email ID and contact number for the process of registration, because that is the only mode of communication. And today is the last day of our polling session. And we totally have 10 questions, and it's mandatory to answer all the 10 questions to proceed with the submission. And the total duration is not 10 minutes, and it is going to be only 6 minutes for the polling session. Because it's being the last polling session, we have a lot of ties, so we need to make it little tougher. So we have 3 star questions, and star questions are taken into consideration only in case of tie. The cumulative score are taken into consideration. The polling session starts now. In case if the participants are not able to visualize the questions, you just have to go tap onto the polls so that you will have your questions displayed. We have got 3 more minutes. Last 1 minute. They are ending the poll now.
Okay, thank you everyone for participating. This ends our session today. We will see you for the next session on 13th. And then as Dr. Kalavani said, we will have the results of the polls on August the 17th. So again, thank you so much, everyone. And thank you, Dr. Kalavani, for again, an excellent session.
Thank you, Dr. Amrish. Thank you. Thank you.